Hello all. Very good morning. Today we'll see about clinical aspects of a ear case. Suppose you are given a ear case in your ENT practical exam. We'll just discuss some major clinical aspects and some important topics that will be essential for your viva as well as for the clinical presentation. Okay, starting with the history. History as such for the pair of the ear case, it's better if it is always in the own words of the patient, not from medical terminology should not be used. So, and the chief complaint should always be in the chronological order as per the duration and severity. Suppose the patient first had um, hard of hearing, that has to be mentioned first, and only then pain has started in the ear. So you'll have to order in that way. And also, whichever is very severe, you can emphasize that as the very chief complaint sometimes. And also, the side has to be mentioned, which most of the students usually forget during the presentations. Regarding the onset of any symptom, it is usually insidious. Insidious in the sense the patient himself doesn't know when it has started. It has just started and gradually it has increased. And that is what is called insidious. They didn't know when it actually started because they have not uh, given much importance to that symptom initially. And gradually, as it worsened, he started realizing that the symptom is there. So you can either say it as insidious onset or a sudden onset. Suppose a sudden ear pain, that is sudden onset. That is not insidious onset. Whereas a growth in the neck, it has gradually progressed. That you can say it as insidious onset, because the initial phases the patient has not recognized that growth. Next, any disease as progression, it could be either the symptoms is gradually increased or gradually decreased, or very fast progression of the symptom could be there. Sometimes the disease symptom could be intermittent, maybe on and off. On and off in the sense, like for example, ear discharge. Ear discharge is most of the time intermittent. Especially when you have a chronic suppurative otitis media CSOM case as your ENT case. And when you talk about ear discharge, you can mention it as intermittent ear discharge, because none of the patient will be having ear discharge for 10 years or 20 years continuously. They would have some treatment and it would stop, and again they get any URI or exposed to, suppose water gets inside the ear, they can have reinfection and they can have episodes of ear discharge. So you can say it as intermittent progression. Next, aggravating and relieving factors for any ear symptoms. It is usually what is the aggravating factor for ear discharge? It is like having a hair wash, an episode of upper respiratory tract infection. All these things are aggravating factors. Relieving factors usually the medication that they receive from their ENT practitioner or from the general practitioner usually, or any other things that relieve their symptoms could be mentioned. The basic ear complaints which they present to ENT OPD is like ear pain, itching in the ear, as in fungal infections of the ear, otomycosis. There is usually itching and watery discharge. And discharge, when you mention, you can always mention the nature of the discharge. Nature of the discharge could be either it is mucoid, that is mucus-like, or it is purulent, or a combination of both mucopurulent, or serous or watery discharge. Color of the discharge sometimes gives you some clue, like for example, if it is greenish tinge, it could be pseudomonas infection because of pyoverdin, pyocyanin pigments in pseudomonas. It can have a colored discharge. And the smell of the ear discharge is also important. As you know, an aticoantral disease where there is bone erosion, you could have foul smelling ear discharge. So all these things are important for ear discharge. Hard of hearing, again, it could be either conductive hearing loss, sensory neural hearing loss, or mixed hearing loss. So it is mostly the conductive component is limited to the external ear and middle ear. For example, stapes fixation as in otosclerosis. Suppose there is some wax impaction in the external canal, the perforation in the tympanic membrane. All these things can cause conductive hearing loss. Whereas sensory neural is like ototoxicity. your drugs causing ototoxicity, some presbyocusis, age-related hearing loss, noise-induced hearing loss, or long-standing CSOM can also cause sensory neural hearing loss, because if the patient has pus for a very long time in the ear untreated, bacterial toxins can imbibe through the round window. It can cause inner ear damage. So that is why the long-standing cases of CSOM can have mixed kind of hearing loss instead of just a conductive hearing loss, which is usual presentation. And also old people who have presbyocusis, that is age related hearing loss, those people having CSOM also are expected to have mixed hearing loss instead of conductive hearing loss. So not always it is conductive hearing loss in CSOM, that you will have to understand. Next, vertigo and tinnitus, these are common ENT symptoms. And in your case, CSOM case, it is usually related to some complications of CSOM. And these things as such is not kept as an exam case. Like only a vertigo case or only a tinnitus case is not usually given. And the ear block, fullness, all these things are usual ENT symptoms. Like even in Meniere's disease, you can have ear fullness. Even a wax could cause ear fullness. Foreign bodies, trauma of the ear canal, any injuries or any deformities, all these things are common ear complaints. Now moving on to the ear examination for a long case, you are expected to mention all these side headings in your case sheet. So start with the pinna, the preauricular region, the postauricular region, the external auditory canal, the tympanic membrane. You can also mention about the middle ear if there is perforation in the eardrum, because you will be able to see part of the middle ear mucosa through the perforation. Then you can mention. Next is Eustachian tube functions. You can also mention about that. And also facial nerve functions, tuning fork test, some special tests like Fistula Test, three-finger test, tracheal tenderness, all these things come along with tuning fork test or special tests. Next comes, as usual for a long case, you are supposed to write nose, throat as well as neck. Without writing about the nose, throat and neck examination, a long case is not over. So even though it is a ear case, you are expected to write all systems. So looking into the pinna, usual common presentation are a big ear pinna like macrotia or a bat ear, the projected ear pinna, or any cup ear, preauricular tags. All these things are some of the abnormalities. Along with that, you know about microtia, nausea, small pinna, or absent pinna. All these things are there. Next is preauricular region and postauricular region. Common presentations are lymph node enlargements in the preauricular, postauricular region, congenital abnormalities like preauricular sinus which may get infected. Postauricular region, again there is could be postauricular lymphadenitis, secondary to some scalp infection or infestation like dandruff, lice infestation, or mastoid abscess. The second picture here is a mastoid abscess. The first picture is a preauricular sinus. You could see a sinus opening here. If it is infected, it can drain pus sometimes. What is CSOM? Basically, this is the case that is given to you. And CSOM as such, it's nowadays the recent terminology is COM, chronic otitis media, instead of the old terminology, chronic suppurative otitis media. Just know this definition, and this is what I have been training my students, this definition. It is chronic long-standing infection or inflammation of whole or part of the mucoperiosteal layer lining the middle ear cleft. It is usually characterized by perforation of the tympanic membrane with or without ear discharge. Why I am saying with or without ear discharge is not all the time CSOM patients will be having ear discharge. If they have medical treatment, they may even have a dry perforation without ear discharge. And why I am saying it's infection or inflammation, because not all the time they may have infection. Once they are treated with medication, antibiotics, they may be free of infection, but minimal inflammation could be there. And it is not the bone, it is usually the mucoperiosteal layer lining the middle ear cleft is involved. The middle ear cavity, tympanic cavity, is different from the tympanic cleft. Middle ear cleft usually includes all these three things. One is Eustachian tube, the middle ear cavity or tympanic cavity, plus the mastoid air cells system. The mastoid air cells The antrum, the largest air cell and the most persistent mastoid air cell is called the antrum, because even though you have some people have a sclerosed mastoid, even for those people, antrum is exposed to be present. Antrum is expected to be present because that is the largest and most persistent air cell in the mastoid. What is the other antrum that you know is maxillary antrum, the maxillary sinus. Do not confuse maxillary and mastoid antrum. Okay, and mastoid antrum communicates to the middle ear cavity through a narrow editus. So all these three I am together calling it as mastoid air cell system plus middle ear cavity or tympanic cavity plus Eustachian tube. All these three together is called middle ear cleft. That is what is mentioned in this definition. It is the problem of the middle ear cleft, not the middle ear cavity alone. Okay, looking at the ear canal, what common mistakes most of the students do is they see ear discharge in a active stage of CSOM, active case of CSOM discharging pus. For those people also, students usually mention it as ear canal, external artery canal, right, left ear, normal. That is not normal. When you see ear discharge, you will have to mention. When you see a stenosis, like it has become narrowed because of some furuncle, you should mention that. If there is some skin excoriation in the canal due to constant fungal infection or associated psoriatic conditions or something, that you will have to mention. It is not always normal. Then how to draw a tympanic membrane? And this is a very important thing because you are expected to draw a tympanic membrane in your long case. In the case sheet, you are expected to draw a tympanic membrane. This is what I drew. It is usually elliptical shape. Most of the people draw it as a perfect sphere. It is not a sphere. It is 11 into 9 millimeter. So I have drawn it as a ellipse, and also I have made it little slanted like this: right tympanic membrane, left tympanic membrane. Always in case sheet, you should write the right ear findings towards the left in the case sheet, because when you look at a patient, you are looking at the right ear this side, left ear this side. So that is how you should write in the case sheet. Do not write left findings here and right ear findings this side. Just like how I have drawn in the diagram, you should always write in the case sheet. Right is always towards the left, left is always towards the right. This is how you should draw. Okay, so I have drawn double layer here because annulus is only present in the pars tensa part of the tympanic membrane. In the pars flaccida, there is no annulus. And also you can see the cone of light is in the antero-inferior quadrant, and the handle of malleus is projecting like this, and the umbo is projecting in a different direction. You can see handle of malleus is here, but umbo is projecting this way. What is umbo? Umbo is that central projection in a shield. What the warriors and soldiers in the olden days, they have a sword and a shield. In the shield, there is a projection in the middle. That is called umbo. But actually, in the tympanic membrane, the umbo is not projecting outward, it is actually inward. So when light is thrown through a headlight, when light is going through some angulation, it is going through the umbo, it will project some light outward. So that is how you get a cone of light when you project light into the ear canal. That is why you get a cone of light in the antero-inferior quadrant. And tympanic membrane, what are the abnormalities that you can find? One is you can find air bubbles like this, such as in cases like SOM, secretory otitis media. Air bubbles are present, and this is one of the most common causes for childhood deafness and also poor school performance in children, the SOM, secretory otitis media. Other one is traumatic perforation after any receiving a slap or any small crackers bursting near their ear. People exposed to such loud noise can have traumatic perforation of the ear canal, the eardrum. So a traumatic perforation, it is usually vertical in shape and has serrated margins like this. And I have drawn some blood clots here. Blood clots are usually very closely associated to the traumatic perforation. Whereas a normal central perforation in the CSOM case is usually spherical or elliptical. It has a definite shape, not a serrated margin like this. So moving on to the central perforation. What is central perforation? It will be asked in Viva. So this is a simple definition. It is perforation in the pars tensa surrounded by pars tensa. So any type of perforation that is obeying this clause becomes a central perforation. The perforation should be in the tensa and also surrounded by a layer of pars tensa. And how do you divide the TM into tympanic membrane into quadrants? Only if you know this, you know where exactly is the perforation. When you mention the perforation in the diagnosis, you should know how the tympanic membrane is divided into quadrants. These are artificial lines, one line drawn along the long axis of handle of malleus. And the second line is drawn perpendicular to the previous line at the level of umbo. So it is not like one vertical line and one horizontal line, because tympanic membrane is not like this, it is angulated. So you should always mention it as one line along the long axis of handle of malleus and other line perpendicular, that is making 90 degree with the previous line. Perpendicular to the previous line, not here, it is at the level of umbo. So that is how you would divide the tympanic membrane into quadrants with two artificial lines. And this is antero-superior, antero-inferior, postero-superior and postero-inferior. Next, we'll see what are the types of central perforation. One is, now that you know the quadrants, I would say any perforation that is too small to just occupy one quadrant is called a small central perforation. Okay, if it occupies two quadrant, you can call it a medium central perforation. If it occupies three quadrants, you can call it a large central perforation. If it occupies all four quadrants, you can call it a subtotal perforation. The subtotal perforation is kidney shaped or reniform shaped, or this is also a central perforation, because you can see a rim of pars tensa around the perforation. So perforation should always be drawn with a single outline. Do not shade the perforation. Shading a perforation or making crisscross lines means it is a healed perforation. Most of the students do that mistake in the exam. Perforation should only be a outline. Do not shade inside or make crisscross lines. Crisscross lines means a healed perforation. So make a single line. It is this subtotal perforation is horseshoe or kidney shaped. Okay. And next is total perforation and marginal perforation. Total perforation is one that involves even the annulus in the pars tensa. So this does not follow the definition of central perforation, because a central perforation should be in the pars tensa, agreed, but it is not surrounded by pars tensa. It is involving the annulus also. So total perforation is strictly not a central perforation, and even marginal perforation could be either in the attic region or in the pars tensa region. It is in the marginal area, so it is not surrounded on all sides by pars tensa, so it is not strictly a central perforation. Marginal perforation in the attic region is not always a perforation. Most of the times it is a retraction pocket. So it is the tympanic membrane in the attic region is gone inside. What you are able to see is only this area. So from outside it looks like a perforation, but it is a pocket, a retraction pocket. It may be a cholesteatoma also. So this thing is very important when you are explaining a perforation in the tympanic membrane. When looking at a perforation in the tympanic membrane, you'll usually use a head mirror, and it will be reflecting a light from a bullseye lamp. The bullseye lamp and with head mirror is only advised for undergraduates. You are not supposed to use a otoscope. That is only for postgraduates. So in exam, you are supposed to use a bullseye lamp and head mirror usually. Okay, so head mirror it has a central aperture that has to be kept in towards your dominant eye. and both the eyes should be open. You should not close one eye, so that because both eyes are important for depth perception, 3D vision. If one eye is closed, you will not be able to access the depth. Suppose there is a foreign body in the ear canal, you will not be able to assess where what is the depth of the foreign body when one eye is closed. So that's why you should keep both the eyes open, but the head mirror aperture should be towards the dominant eye. Suppose I am a right-handed person, I will keep in my right eye, and the distance between the head mirror and the patient should be 18 centimeters, because that is the focal length of that plano concave mirror. It is a mirror, whereas what is there in the bullseye lamp is a lens. That is not a mirror, that is a biconvex lens. Its focal length is 40 centimeters. So you'll have to keep the bullseye lamp some 10 centimeters behind and lateral to the patient, left shoulder of the patient, behind and lateral to the left shoulder of the patient. From there, it has to be 40 centimeters from you, the light. From you, between you and the head mirror and the patient, it should be roughly around 20 centimeter or 18 centimeters, so that the focus will be good. Okay. And while sitting and examining a ear case or any ENT case, preferably both the surgeon, both the doctor and the patient should be in a revolving stool, which is height adjustable, so that even if it is a kid, you can ask them to sit on their mother's lap. You can increase the height, decrease the height to be in line with your vision. So it's preferably a rotating revolving stool for both the doctor as well as the patient, and never crisscross your legs like this. It should be always your legs this side, patient's legs this side, or patient's leg this side, your leg this side when you are examining and sitting in the chair. Never crisscross your legs with the patient like this or do like this. It is not advisable, be it male or female patient. There are ethics in clinical practice. You should sit properly and never crisscross your legs. Next, when you put a light and examine the tympanic membrane, these things has to be emphasized about the perforation. The examiner will be keen to know about all these details. You should tell the examiner where exactly, which quadrant does the perforation occupies, whether it is in the anterosuperior quadrant or which quadrant, 2 or 3 quadrants does it occupy. You should mention in sight. Next is size of the perforation. As I told you in previous slide, the small, medium, large, subtotal, or this thing you'll have to mention in the size. Next is shape. Shape of the perforation, it is to differentiate traumatic perforation from CSOM perforation. Traumatic perforation, I already told you, it has rugged serrated margins, and more or less it is vertical in shape. Whereas CSOM perforation has a definite round margin or a oval or elliptical shape, or a subtotal kind of shape. Why it has definite margins? Because in central perforation, in the CSOM kind of perforation, there is fluid pushing, that is occupying the middle ear, infected pus and mucus. It is pushing the eardrum outward. At one point, the tympanic membrane gets its blood supply from all around like this, from a radiating pattern. Suppose the middle portion is pushed outward, the tympanic membrane is moving outward because of pus pushing it outward. It is devoid of, the middle portion is devoid of the blood vessels. There is no blood supply is cut in the middle portion. So blood supply cannot reach the middle portion when it is bulging out. So this area, the middle portion, becomes avascular region, and it becomes necrosed, and the tympanic membrane perforation starts. That is why in the CSOM perforation, that is definite circle or elliptical shape or subtotal kind of shapes. Whereas a traumatic perforation, it is because of pressure, you have serrated margins. And structures seen through. So in regarding a perforation, 4S you will have to remember in mind. One is sight, size, shape, and structures seen through. Structures seen through is the middle ear mucosa. In the active stage of CSOM, you will always see pus or mucus, mucopus in the middle ear, or congested middle ear mucosa, reddish, pinkish mucosa. Whereas in the inactive stage of CSOM, you would see a very pale, dull middle ear mucosa. That means inactive stage, there is no active discharge. And about the shape, we should emphasize about the how is the margin and edge of the perforation. What are margins and edges? As you can remember from surgery classes, any wound ulcer has, suppose this is the ulcer, it has a margin like this sharp area, and there's a space between the margin and the floor, that is called edge. So this middle portion is the edge. Instead of floor, here there is perforation. So in the perforation also you can think of this. So here instead in an ulcer you have floor, whereas in a perforation you have you could see the middle ear through this perforation. So everything is same in the structures seen through is where this floor is there in the ulcer. So just for comparison, I have put a picture of a ulcer parts. So this is margin, this is edge. In a perforation, central perforation, usually the margins are definitive. It is not serrated, not rugged like in traumatic perforation. So margins tell you whether it is traumatic or central perforation. The edge, the space between the margin and the perforation here, this portion is usually either healed or unhealed. If it is raw area, suppose there are 3 layers in the tympanic membrane, both sides, there is a perforation in between. So normally when it is expected to heal, the outer epithelial layer joins with the epithelial layer, inner mucosal layer joins with the mucosal layer, but the middle fibrous or muscular layer retracts. It never joins. That is why healed perforation has only 2 layers of tympanic membrane instead of 3 layers, and it is always weak when compared to the normal tympanic membrane, because the middle layer does not join. So in the edge, suppose there is a long-standing central perforation, there is healed edge. The outer epithelial layer seals with the inner mucosal layer, and the middle layer is retracted. These 2 layers fuse. The outer and inner layer will fuse together instead of outer layer fusing with the outer layer. So both these edges are fused. Now it becomes already healed. Now it will not join together. Natural healing will not take place unless you cauterize this place with chemical cautery, or you do tympanoplasty. You cut off this healed portion and make it raw and put a graft. So this is healed perforation. It is called healed edges. It is called permanent perforation syndrome. This will never heal on its own. Whereas if it is raw, it's a fresh perforation, the outer epithelial layer and inner mucosal layer are still raw to join together. You can give some time for natural healing. Next, moving on to the tuning fork tests. Tuning fork tests, usually these 3 tests are done, Rini, Weber and absolute bone conduction test. These tests are done to assess the hearing. You should have in mind that tuning fork test can assess the hearing quantitatively as well as qualitatively. You can either find whether it is conductive hearing loss or sensory neural hearing loss qualitatively. You can even assess whether it is how worse is the degree, whether it is mild, moderate or severe, using 3 different frequency of tuning forks. The tabular column will be there in your textbook. You will have to use 3 different tuning forks to assess degree of hearing loss. Okay, now that is not very important. I'll move on with how to do Rini, Weber and ABC. So we usually use a 512 tuning fork, 512 hertz tuning fork. This vibrates 512 times in a minute, in a second, and we use this because 512 tuning fork is this frequency is very close to the speech frequency. Humans can hear from 20 hertz to 20,000 hertz, whereas they can speak only from around 300 to 3,000 hertz. So you know people saying they are able to hear properly, that there is no problem in their hearing, because they are saying what they are able to converse properly. But whereas when you subject the same patient to pure tone audiometry graph, you could see lots of variations, lots of hearing loss in different frequencies, because patients always think about speech frequency alone. So when I want to assess the hearing with the tuning fork, it is better to use a speech frequency to assess tuning fork. That's why I select 512 tuning fork. Also, when you select a lower frequency tuning fork, it produces more vibrations, because when you do like this, you feel more vibration. If it is 128 tuning fork, you feel more vibrations here. Whereas when you take a 1024 or 2048 tuning fork, it is very fast that you don't feel the vibration, you can only hear the sound. So higher tuning forks produce overtones for more sound. Lower frequency tuning forks produce more vibration. So we are avoiding both the higher and lower frequencies and picking the middle 512 tuning fork, which matches with the speech frequency. Okay, that is why we take a 512 tuning fork. This is how Reni's test is done. Reni's can be performed in two ways. One is just comparing, keeping the base of the tuning fork over the mastoid, and one close to the external artery canal, some 1 inch from the external artery canal, with the vibrating prongs in line with the axis of external artery canal. It should be kept like this, not like this. Okay, so that is how it has to be kept. And you can compare whether you can ask the patient, this is better or this is better. Patient will say always, normal, the air conduction is better, but this is better, and instead of the mastoid area. The other method, the better method, which I usually follow is, you first keep it over the mastoid, the base of the tuning fork, and once the patient stops to hear, ask him to raise his hand. Once he stops to hear, immediately keep the prongs like this and check for air conduction. Then if the patient is still able to hear, it obviously means air conduction is better than bone conduction, because even after the bone conduction has stopped, he is able to hear the air conduction. So this is another method of Reni's test. So first keep here. Once the patient stops hearing, keep it here. If he is still able to hear, it means air conduction is better than bone conduction. You can mention it as plus sign in Reni's test, or AC is greater than BC. These two methods are preferable to write in a chart. Right side, left side, plus on right side, negative on left side if there is a perforation in the tympanic membrane. You are expected to have conductive hearing loss. In that case, it will be a negative Reni's test. Suppose there is a left CSOM case, you are going to do a Weber's test. Weber's test, you can keep over the bony vertex, you can keep over the glabella, or you can keep over the upper incisor, not on the lower incisor, because lower incisor, the sound conducts through a temporomandibular joint, so it is not reliable. You can keep over upper incisor, but it can get contaminated with the saliva, so it's better to do over the forehead or in the vertex. So when you keep there, you ask which side vibrating tuning fork, which side the patient could hear should be asked. Suppose the patient has left sided CSOM, you would say he is able to preferentially hear on the left side, because Weber's is directed towards the side of conductive hearing loss. Also, you should tell the patient properly that they should always tell only the sound, not the vibration. Even while doing Reni or Weber, people get confused with the vibration over the mastoid instead of sound. You should only ask the patient about the sound. This sound is better than this sound, you should ask. You should not compare the vibration with the sound here. Okay, it is only the sound that is important, not the vibration. Next is absolute bone conduction test. The third picture here is actually showing the bone conduction testing, keeping the base of the tuning fork over the mastoid region. But what is absolute bone conduction test? You do only bone conduction and you cut off air conduction. So that is why it is called absolute bone conduction. How do you cut off air conduction? You just give tracheal pressure, it occludes the external auditory canal, it cuts off the air conduction. Thereby only bone conduction is tested. So how do you do that? You occlude the canal by giving tracheal pressure to the patient. Then you keep a vibrating tuning fork on the mastoid region, the base of the tuning fork. Once he stops hearing, ask him to raise his hand. Immediately you keep the same tuning fork on your mastoid, closing your external canal by giving tracheal pressure. If you are able to hear still, even though the patient has stopped hearing, but you are able to hear still, it means there is sensory neural hearing loss for the patient. It means reduced. In the absolute bone conduction test, you write it as reduced R. If even you are not able to hear, you can write it as NR, not reduced. So in the tabular column, for any you can write plus or minus. For Weber's test, you put a double-sided arrow normally, or if it's conductive hearing loss left side, you can put a left-sided arrow. If for absolute bone conduction test, you can write not reduced or reduced. If it is reduced, it means that side there is sensory neural loss. Facial nerve examination is part of ear examination. You should look for facial symmetry, absence of nasolabial folds, this frontal folds, whether the patient is able to close the eyes properly, one side or both sides. All these things should be tested. And sometimes there will be excessive tear secretion one side because eye cannot be closed. So tears will be rolling down, or drooling in mouth, or dryness of eyes could be noted. And even drooling from the corners, angles of mouth, or any mouth angle of mouth deviation, all these things are noted. You can ask the patient for facial nerve function, like asking them to blow. You can check for the muscles also, checking the peripheral branches of facial nerve. This is a separate topic. So these things are noted, like angle of mouth deviation, inability to close, or forehead brow movements. All these things can be assessed. The special tests, just for completion, you can ask giving tracheal pressure, if there is pain or not. Suppose there is tenderness when you press the tragus, it means external otitis. That is, otitis externa. There is some inflammation of the external artery canal. Could be a furuncle also. Okay. What is furuncle? It is Staphylococcus aureus infection of the hair follicle. Next is fistula test. What is fistula test? You do give intermittent pressure over the tragus. Intermittent is give and don't give. Like keep repeating this. When you do the fistula test, patient can have nystagmus or vertigo if there is a fistula in the semicircular canal. Next is 3-finger test. You use thumb finger, index finger, and middle finger to give pressure over the conical bowl, or the mastoid body and tip of mastoid, to find out whether there is mastoiditis, lateral sinus thrombosis, or tip cell mastoiditis. Other one is Eustachian tube functions. Tube function could be assessed by Valsalva maneuver, that is pinching the nostrils, closing the mouth, and blowing air inside your mouth, like building air pressure inside your mouth. You will feel the ears popping both sides normally. That is Eustachian. Well, suppose one side is not popping, it means there is Eustachian block on that side. Other thing is Toynbee maneuver, pinching the nostrils, closing the mouth, and swallowing saliva. Then also you will hear both the ears are popping, because the palate is closely associated with the opening of Eustachian tube, the tensor villi palatini muscle. So during the movement of swallowing, you can see ears are popping with eyes and nose and mouth closed. So these are other things that you should know about the positive fistula test and false negative and false positive fistula test. Fistula test positive means there is some fistula or opening in the semicircular canal. So now when all do you have a positive fistula test is when you have a erosion of the horizontal semicircular canal, any fenestration surgery has been done. Post stapedectomy, there is surgically they make a opening to keep the piston, and other thing is any rupture of round window. All these things you can have a positive fistula test. When do you get false negative fistula test? There is a fistula, but the fistula is that opening is covered by a cholesteatoma. In that case, you will get a false negative fistula test. Or when the inner ear is dead, even though the fistula is open, when the inner ear is dead, it is not going to respond. So there is no nystagmus or tinnitus, no nystagmus or vertigo. Sorry. When do you have false positive fistula test? When you just give intermittent pressure, it is hyperacting. The normal stapes that is moving this much is going to move this much. When does it happen is congenital syphilis, you will have hypermobile footplate of stapes. And the other thing is when Meniere's disease also you can have false positive test, because the stapes is connected to the utricular macula by fibrous bands. So it overreacts when you do a fistula test. You can have a false positive also, even though there is no fistula in the semicircular canal. Just for completion's sake, we'll see what is cholesteatoma. This is often confused thing, and most of the books do not give a proper definition. So you can note this definition. It is called a cystic bag-like structure. It is lined by keratinized stratified squamous epithelium. It contains desquamated keratin debris overlying a fibrous stroma. It has a propensity to cause bone erosion because of its pressure effects and also the enzymes that it secretes. So the same definition I'm explaining. You know, ear canal, this external ear, middle ear canal and middle ear and Eustachian tube. Ear canal is a skin-lined cul-de-sac. It is lined by skin. No, it is peculiarity of the external ear. Whereas in the mouth or nose, it is not skin entirely. Whereas in the ear, it is the outer layer is skin completely. So this is skin going inside and coming out as like a epithelial layer, outer layer of tympanic membrane, and again it is skin. So everywhere it is keratinized stratified squamous epithelium. In the attic region, because there is no middle layer, it can retract. The tympanic membrane only has two layers in the attic region. So it can retract due to various theories of formation of cholesteatoma. It can go inside the middle ear, it can go inside and form a retraction pocket. This retraction pocket is again lined by keratinized stratified squamous epithelium. You know, skin has a ability to shed old skin, that is desquamate. The old skin is shed out and new skin grows. So when skin is there in the wrong place, in the middle ear is actually mucosa. Instead of that, there is epithelium. So this actually sheds the dead skin inside itself, and dead skin keeps collecting over a fibrous stromal elements. These are stromal elements over that desquamated dead skin or desquamated keratin debris collects, and because it is collected more and more out of its own weight, this grows in size. It becomes bigger and bigger and bigger and gives pressure over the ossicles, over the inner ear structures, over the roof, over the floor, and causes cholesteatoma problems. Now you can understand it is a cystic bag-like structure, lined by stratified squamous epithelium containing desquamated keratin debris, which is desquamated from the skin, overlying fibrous stromal elements. So which has a propensity to cause bone erosion. This is called cholesteatoma. Cholesteatoma is one of the unsafe pathology, that is atticoantral disease has granulation and cholesteatoma as pathologies. These things are usually PG cases, not usually given for undergraduates, but it is very important in Viva as well as in theory exam, cholesteatoma. Just for your understanding and completion sake, I have told about cholesteatoma. So in diagnosis is very important. Diagnosis in a CSOM case. All these points should be emphasized. You should say it's a left chronic otitis media or chronic suppurative otitis media. Which side is important? Most of the students forget the side in the diagnosis. Next, which type of CSOM it is? Tubotympanic or atticoantral disease? It is tubotympanic disease. And which stage of the disease is it? Whether it is active stage, that is active stage of discharge, quiescent stage, or inactive stage, you'll have to mention. And also what kind of perforation, if it is a left subtotal perforation or left small perforation occupying the anterosuperior quadrant, you can mention it here. And what kind of hearing loss does the patient have? Left-sided conductive hearing loss. With the tuning fork test, you'll be able to know this. Left conductive hearing loss or mixed hearing loss, you can mention. And with or without complications, you can mention. So all these points are mandatory in diagnosis. Only then you will be able to come to a treatment idea. Suppose it is inactive, there is no use of giving antibiotic ear drops, or there is no use of doing oral toileting. I have seen many patients writing it as inactive stage and mentioning in treatment as oral toileting. It is already dry. Where is the necessity to do suctioning or dry mopping? There is no use for all these treatment. So diagnosis is very important. Only with the diagnosis you should tell appropriate treatment. Okay, so this is all for today. I'll conclude the class. Anything very important topic that you are interested, let me know. We'll try in near future. Thank you.